This My name is Mohammed Sani Abakar from FTH Katsina. This morning we are going to have a brief discussion on question 8 of National Postgraduate Medical College 2023 May OSPAC. The question goes as follows: You are the new head of a 75-bedded stroke unit with 1 neurologist, 2 physicians, 5 nurses, 3 porters, 2 physiotherapists. The outcome of the stroke unit in the ward has been reported to be very poor. Define clinical governance. That's option A, question A. List the pillars of clinical governance. Then use any 3 pillars to address the problem above. For each of the pillar, give the definition and list the components of the pillars. And this question is on clinical governance, and it's a very important component of the Part 2 examination, especially in National Postgraduate Medical College. And the main objective is for clinicians to be armed with skills to solve clinical administrative problems that are related to clinical issues that are a common event in our day-to-day activities in the hospital. Now, before briefly I go into the discussion, it's good for us to remind ourselves about the recommendation of the American Heart Association and what needs to be done in a patient that has stroke, from door to provider and also up to admission to stroke unit in ICU. Every care the patient needs to have should be within the golden 3 hours of stroke. And this has been shown to have significant improvement in clinical practice. And as you can see, the care usually starts from the point of event, from where the patient has the problem, be it in the home, in the sport facility, on the road, in his office, restaurant, cafe, wherever the patient has, from the time the patient has the event to the time it gets to the first contact, usually the ambulance or usually the mobile medical system, it's usually 10 minutes. Up to the time the patient have the intervention of the ICU should be within the first 3 hours. This is the golden 3 hours that we always mention. Now, looking at this case, looking at this question, before we start answering it, we need to understand what are the key points. And the key point is, this is a stroke unit with 75 beds. But the only staff strength in the center are 1 neurologist, 2 physicians, 5 nurses, 3 porters, and 2 physiotherapists. Now, there are 2 problems that are here. First, not all specialties or not all staff are represented here. There are some staffs that are still missing from the list. 2, the staff strength is small. It won't be able to cater for those 75 patients that may be on admission if the beds are all occupied. So those are 2 main issues that we're going to look at. Now, staff strength has been assessed by many institutions all over the world. And usually the assessment usually starts with 6-bedded strength or 10-bedded strength. Now, if you're using a 6-bedded strength, 6-bed stroke unit strength, you expect to have a neurologist that should always be around. Then an internist, probably a physician, that also should be around, but not necessarily around on ground. But he can hang around in the call room or somewhere where he can be paged, he can be called immediately. A neuroradiologist or radiologist or interventional radiologist that will be needed anytime to review, especially if there's deterioration, so that MRI, CT can be done and it can be interpreted on time. Then the nursing to patient ratio should be around 1:1 or 1.2:1. It's not ideal, but what is advocated is usually 1 nurse to 1 patient. That is the advocacy for a stroke unit. Now, other specialists that are needed are physical therapists, speech therapists, because those one are key in recovery, occupational therapists, because some of those patients, some of them can be drivers, can be factory workers, they can be bankers. So they need occupational therapists that will tackle them. Then there will be social workers, especially in times of need. If the patient is out of funds or he has one social issue, he needs to be addressed. Then there should be a secretarial staff that should be equipped, that should be handled that. Now, some of the important investigations are listed below. I won't go through them because this is more of clinical governance question rather than entire clinical aspect. Now, looking at the option A, they say clinical governance. They are asking for many definitions. There are many definitions to clinical governance. It doesn't have to be the definition that we see in our books or in our literature. The most important thing is for us to know that clinical governance is a system through which organization or health institution are accountable for continuously improving the quality of their services. At the same time, safeguarding high standard of care and minimizing risk by creating an environment in which clinical excellence will flourish. So in clinical governance, you're trying to give the best care. At the same time, you're also looking at not compromising the standard of care that is found all over the world, so that services can continue to be given with high level of excellence. And this is what is continuously advocated in our setting. Even though we know our setting with low resources, with deficit in healthcare facilities, but it's still advocated that we have to give an excellent care to our patient. Now, it's also a systematic approach to maintaining and improving the quality of care. Whatever it will take for the administrator, for the clinician, for the head of the unit to ensure that quality care is given is part of clinical governance. It also defines as the framework through which healthcare organizations are accountable for continuously improving the quality of their services and safeguarding high quality of care. So if you look at all the three definitions, the most important thing is the institution giving high quality care, maintaining excellence, and giving quality care to our patient. These important things are not compromisable in our clinical setting. Now, comment option question, the second segment of the question, they say, what are the pillars of clinical governance? And there's a popular mnemonic that's usually used in clinical practice to remind us of the 7 pillars or 7 components. And they are as follows: risk management in the hospital setting, education and training, clinical effectiveness, clinical audit, openness, teamwork and communication, research, and then finally development. This mnemonic are termed as record. Now, this is also a simple diagram to give us an idea of the flow of clinical governance. The clinical auditing, which is very important, especially and this should be advocated as frequent as possible. Many centers have their own schedules, weekly, monthly, but ideally it should be as frequent as possible, because this is where an individual will get to know what is he offering to the patient, what quality is given, where is the deficit, especially if there is morbidity or mortality attached to a particular case that's managed. Clinical effectiveness, risk management, use of information, education and training of your staff. This is through CPD, CME training, and other specialty training, staffing, and staff management, especially when it's come to crisis resolution, institution of change, and a lot of things. So administration should be able to handle that. Then client and career experience and involvement. This is very important, especially in case of medical legal problems that the patient may be. And this is also a summary. Now, sometimes the traditional 7 pillars may have an additional 8 component. And this one is the governance structure. That means a way of adjusting the hospital running or the institution running so that everyone is accommodated and has clear understanding and clear involvement, so that one unit, doctors, nurses, physiotherapy, and everybody has a particular role to play when it comes to the running of day-to-day affairs of the hospital. Now, the third portion is the risk management, and it involves identifying, assessing.
Hello, Chief. You have 1 more minute.
The third component is risk management. It involves identifying, assessing, mitigating risk to prevent harm to patients. And this is where the clinician or family administrator look at ways to give the quality of care with minimal risk to the patient. And the components are identifying the risk, assessing the risk, and treating the risk if possible. Then the last one is monitor and report on the risk. It's very important for individual to document the flow of management of the patient and even challenges so that the future occurrence will be avoided. So in this case, you are exposing patient to risk based on the understaffing of the stroke unit. So more staff strengths need to be deployed stroke unit so that to minimize the risk those patients in stroke unit are looking at the mortality that was reported to be poor. Now, education and training. Now, in the case where the staff are less, and also there are no skilled personnel to be there, so the clinician or probably the administrator or the head of the institution should look at ways of ensuring training and regular education or lectures to those staff in the facility so that their knowledge is refreshed, their skills is improved so that they can manage. And the components there are ensuring competency, promoting best practices, facilitating adaptation to change, especially that's what is very important because if you are bringing a new change to the system, you have to know how to handle that change. You may encounter resistance, you may encounter even reluctance, you may even get outright rejection of those changes you are bringing. So you have to develop skills for change institution. Then also you have to enhance teamwork and communication. It's very important for us to communicate. And this communication can actually be active and passive. You have to encourage your staff to pick up those change. And clinical effectiveness, which is the last part from the question, is the primary aim is to integrating clinical effectiveness with clinical governance to enhance patient outcome. And this is very important because looking at the question we measure, you have to find a way of measuring the care you are giving to patient. That means the input. They also have to gauge the output. What are you giving? What is the output? Are patient improving? If patient is improving, it tells you that you have to go back and adjust either your guideline, the policy, or the running of the stroke unit. You also have to share example of good practice through networking. You have to communicate between your center and other centers that have good outcome so that your staff can get motivated so that you can see your deficit. You also have to get strategy development to help meet local objectives in the hostel. You also have to develop effective local steering of group. So sometimes you may need micro cohorting. You may have to develop, you have to make the stroke unit with smaller units so that you can get input. You can even improve practice rather than leaving the stroke unit because 75 beds is quite big. So you can make micro cohorting in the stroke unit so that you can easily manage the system and the problems. So with this, I've come to the end of my discussion. And if you can see, these are the main pillars of clinical governance. And with this, I say thank you very much.
Oh, thank you so much, Dr. Sani, for that beautiful presentation. Okay, so now we'll take comments and questions from the participant first. So you can drop your comment on the chat or you raise your electronic hands and then keep the thanks coming on the chat. Thank you so much. Dr. What is saying thank you. Okay, I can't see any hands up yet. Okay, let me just ask my question. I don't know, in the question, they said a neurologist and 2 physicians. And then in that, please, can you move the slides? There's this ideal stroke unit you put up. It also said a neurologist and an internist. So I didn't quite get what's the difference between the neurologist and the physician and the neurologist and the internist.
Very much. Thank you very much for that. Now, if you look at the question, they said 2 physicians. They have not specifically specified the specialist because leaving a neurologist alone may not be advisable sometimes because there may be a lot of patients that may need attention. So having a more junior specialist than the neurologist is advocated. And like I mentioned, there are many centers and many hospitals differs in what they offer. Some keep the internists, and internists usually, if you in the United States, usually are those what we term as house officers. But sometimes some of them are not house officers in English, sorry, in British terminology. Some of them can be doctors in training or doing residency. They may be attached to those stroke unit. This second slide, just trying, this one is for the 6-bedded stroke unit. Sometimes for the 10-bedded stroke unit, that's when you see usually at least 2 medical officers or 2 residents or 2 physicians in training that will be available. The neurologists, if looking at our case, having 75 beds, you may need up to like 6 or 7 neurologists that will be doing rotational service at that point for those patients. It's not advisable for one neurologist to be taking care of all those 75 patients. It's not part of the clinical governance because the efficiency of giving services and work burnout may be an issue in those facilities. So it all depends on what you have on ground, and that is where clinical governance is very important. You may have the ideal, that is what you are expected, but in looking at your staff strength and the rest, you may have to adjust and use the available staff in that point of time. Thank you.
Hello.
Hi, thank you.
Hello.
Okay. Go ahead, sir. Go ahead, sir.
Yeah. Please let's not forget that the fact that someone has a stroke does not mean they cannot have other comorbidities that require specialist review. Okay. For example, somebody can be diabetic and have stroke, and then you might need the services of an endocrinologist. Okay, so physicians can cover any other specialty apart from neurology. You understand? Okay, so let's just keep that in mind. I hope we understand what I'm saying.
Yes, sir. Thank you so much, sir.
All right.
Okay, so Dr. Osani, there's a lot of thanks for you on the chat. And then Dr. Florence, Dr. Mustafa, then Dr. Ifoma says thanks. The last question wasn't answered. I think she's thinking you didn't quite answer. She didn't understand the answer to the last question. And others are saying thanks. And Dr. Musa is adding the neurosurgeon should also be available. Okay, Dr. Sandy, do you want to make a comment on that?
The last question, I think, I can't remember because I thought the question was more of the physician, and I think Chief Ramikos have answered that. I don't know whether she can specify the question or the point so that I can make it clear.
No, the question says use any 3 pillars to address the problem above.
Okay.
For each of the pillars,
so I think
give the
mention the
definition and
component.
list the components.
I think I answered it here. I started with risk management, then education and training, then clinical effectiveness. Those are the 3 deficiencies. And I think I've explained based on the question, especially like risk management, the fact that you are understaffing the stroke unit, you're putting the patient at risk because efficiency is a problem here. So, and the component to risk management is to identifying the risk, and the risk here is understaffing. You're assessing the risk. The understaffing has a negative consequences in managing a patient because of lack of efficiency. Then how do you treat the risk in this patient? Is by improving the system, by probably staffing or listening, by motivation, by bringing in new change that you think can handle the reality on ground. Then very important is to monitor and reporting of the risks so that clinical auditing can be started. And the other component is the problem is lack of maybe education and training, because if the administrator or probably the clinical audit knows the ideal staffing and probably requirements for opening a stroke unit, they won't go ahead and open stroke unit. They will make sure that there need to be adequate staff to man the stroke unit. So in this, you need that means that the administrator and everyone need to be armed, need to be told about what stroke unit is. That's then you also have to promote the best practices that a stroke unit, because for them to go ahead and open stroke unit with less staff, it tells them that maybe they are not conversant with how a stroke unit need to be. It's not a normal ward. It's somehow equivalent to an ICU or a critical care unit, because you are giving a special care to those patients. Then also you have to, because if you are bringing this change, also you have to anticipate change coming in. And in this, you have to know how to handle change in clinical setting. Bringing change to what is the normal in hospital is a difficult thing. We have experience with our center like FTH. When EHR came in to improve the system, there was so much resistance for electronic health record, so much resistance that people are ready to push it out by force. But as I'm talking to you, with tactics, with modalities or process of change adaptation, I can tell you now it's a story, it's a past story, because now our center is fully fledged EHR center. They also have to enhance teamwork and communication. Sometimes it's not about bringing staff and equipment. You need to also communicate, show them the vision and mission of the stroke unit. This is what we want to achieve. This is what we need. This is what. So by the time your people buy into your idea through communication and teamwork, I think they will pick it up. Then clinical effectiveness, because this is one of the most important in this, because you have to determine your primary aim of opening stroke unit. If you have not defined your aim of opening stroke unit, then definitely the aim, the target will be defeated, because the staff there and even other administrators may not buy into your idea of even buying the equipment or even sending people for training. So it's about selling the idea of giving a world's best care to your patient is the main aim of opening there. And here you have to be scientific. You have to give a measure of input and output. Without monitoring your input, that means the amount of money, financing, the amount of staff you are committing, you also have to measure your output. And output is based on what? Less mobility, less mortality in those patients, and probably fast recovery in some of these patients. Those are the ones that will give us an idea of effectiveness of giving care to those stroke patients. So then other points are as mentioned.
Okay.
I hope I have said a small thing.
Yeah, thank you so much. Thank you so much, Dr. Sani. Okay, Dr. Linda, please go ahead.
Okay, thank you very much for your presentation. I actually just read my comments in the chat. I just wanted to make a correction that an internist is an internal medicine physician, while an intern is a houseman or someone who just finished house job. So there are differences. They're not the same thing. Thank you.
Thank you so much. Dr. Salim, please go ahead.
Okay, thank you for the opportunity. Good morning, all. Dr. Sani, it's an excellent presentation. However, I'm just thinking aloud that looking at the question and looking at how it was structured, I think the major concern is the mortality. They are recording a lot of mortality. So even though we are given the opportunity to use any of the three clinical governance, any of the components, I think it would have been wiser if you had started with clinical auditing and pressing more attention to it rather than the other risk stratification that you ought to in the first place. So I'm just saying that in essence, maybe perhaps hammering more on the audit first will have been better. Thank you.
All right, thank you, Dr. Salim Ahmed. Okay, so we don't have more comments and more hands up. So I'll hand over to our teachers. Mark Christabel.
Thank you so much. Please, I'll just comment on the last comment. Risk assessment is also very important. So I agree with Dr. Sani here. Clinical audit is nice. There's a very slight change. There's very small difference between risk assessment and clinical. They are quite similar. So I'm in support with us what Dr. Sani said. So if he started with risk assessment, it's not bad at all. You also start with clinical audit, it's also not bad. So he did not do badly by starting risk assessment. So I don't know if any of our facilitators have any comment. Chief Koke, Chitu, Bansi, Emingus, Kubi, Fatima, Dahatu. Go ahead, sir, please.
Thank you, Dr. Christabel.
Thank you, sir.
Yes, supporting what you said about risk management is very important in this situation. Okay, but I have to also agree with the last speaker about clinical audit. Clinical audit is something that I'm sure they would have expected, or the person that said this exam would have expected the candidate to mention. Okay, so please, especially in this kind of scenario where you have increased or high mortality rates, clinical audit is very important. Okay. I mentioned the components. I would have expected that should have been part of the three that were talked about. Okay, but of course, it doesn't reduce the fact that risk management is also very, 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 very important here. Okay, so I think that's just what I wanted to say, that out of that three, you should have mentioned clinical audits. Okay, thank you.
Wait, did you mention clinical audit?
No.
I must have missed that. No. Clinical audit more, risk assessment more there. They are quite important. You can't miss saying this too. So Dr. Sani, please.
Yeah. Hello, Dr. Christabel. Sorry, my network has been on and off. I
Go
wanted to
ahead,
comment
sir.
on this risk assessment and clinical audit thing. Part of clinical governance is knowing which one you should use. Because
exactly
the first step of either doing a risk assessment or a clinical audit is to determine if that's the best way to solve the problem on ground. Okay. It may even be important to do both. Okay, because doing a risk assessment will tell you the gravity of the problem in the hospital and the need how much need you have, the need to fix the problem, so to speak. Okay. While the clinical audits, yes, will help you to assess where the problems are and where you need to improve. Of course, weighing it up with the standard as pointed out in the study. So part of clinical governance is determining whether you need to do a risk assessment or a clinical audit. So I think both are important. And if I was in the exam, I'll perhaps mention both. And I would mention the fact that yes, clinical governance should be able to direct me. Good clinical governance would make me decide on which one to use, or even do both, to be sure of what we have on ground. So it's not like one replaces the other. It's just what you assess. Are you trying to assess how bad the situation is? Then that is risk assessment. Are you trying to improve the situation and make it better, or figure out where the problems are and fix them and sustain that improvement? Then you do a clinical audit. Yeah. That's just what I wanted to add before my network disappears again.
Oh, thank you, sir. So that's what we're also saying, that both has to come in whichever order, but both has to be there. If we say risk assessment first, clinical audit first, doesn't matter. They both has to be there. They are both important, especially for this clinical scenario that was created. So thank you, our dear chiefs. I don't know if there are any more comments. Any comments? Oh, thank you. Otto Puter, can go ahead, please.
Thank you very much, Ma. I was wondering, when they say risk assessment as one of the pillars of governance, I was thinking it was pertaining to maybe the assessment of falls or the VTE prophylaxis, or as in assessing this patient, the risk about how concerning pertaining to patient safety. I don't know. I just wanted more clarification on it. Thank you.
Dr. Sani, that's not it. It's quite similar to clinical audit. It's more elaborate. Dr. Sani, can you just summarize for her before we move to the next question?
Thank you very much for that. Risk assessment or management is a bigger, broader term. In short, when I was getting the slide, I was like, okay, for clinical governance to have risk management and audit, there should be two different things. But along the way, I realized clinical audits sometimes can even be part of even the risk management assessment, because in risk management, you're not only tackling the problem. First, you even have to know the extent, the deficit, the problems, the contributors, the factors, before you start to look at each component. So it's not a risk management is not only looking at the clinical aspect of DVT. No, it's looking at the holistic institutional structure. Because if you have a problem with light in the hospital, it's still part of risk assessment. If you have a problem with feeding or something, it's still part of, you're trying to find the risk assessment. It's not only to the clinical or the medical aspect. It's looking at the structure of the hospital, and that's what clinical governance entails. It looks at the care in totality rather than the clinical aspect of the care. So that there are different things. The looking at the DVT prophylaxis and other complications are still part of, they can fall anywhere. Because if you look at education and training, if you don't tell your staff the importance of DVT prophylaxis and the rest, they may not know. If you look at information, that means sharing of information and the rest is there. If you look at staff management, so every component, if you pick one patient or one specialty, you can find all the components there. They are not mutually exclusive. You can get 1, 2, 3 in together in one case. You may not have to see some pillars in other case. But the most important thing, as you are seeing the patient, you should keep in your mind that any one of the 7 can have a role to play if you are seeing a patient. Example, you come to see a patient, there's no CT scan. You can't just start accusing the patient that, why didn't you do CT scan? First, you have to listen. Why was CT scan not done? The problem may be there may be faulty CT scan. There may not be light. They may not have funds to do. Or they have done, there's problem with interpreting. So that is why clinical governance come into play. Thank you very much.
Thank you, Dr. Sonny. Thank you so much. Dr. Mir, I hope that's understood. Thank you.
Let me just add this, Dr. Christabel. Dr. Pute, the risk that we're
Yes, sir.
talking about here is any negative or anything that can impact negatively on patient, staff, or the hospital is a risk. You understand?
Yes, sir.
Anything. So it's important to assess these things and manage them. And that's what risk management is talking about.
Okay, sir.
How do you assess this risk, their impact, positive and negative impacts? How can you mitigate them? No matter the type of negative occurrence. That's what the risk is all about. It's not just about patients, risk to patients. No, it's about every negative thing that can happen in the hospital is a risk. You understand?
Yes, sir. Thank you so much. Thank you, Ma. Thank you, Dr. Christabel. Thank you. Thank you, Dr. Remigos.
So thank you, Ajis. Thank you, Dr. Sunny. Thank you so much. That was quite a wonderful presentation. I appreciate your effort. Thank you. Dr. Ekele, let's move to the next presenter. Thank you.
All right, thank you, Ma. Thank you, Dr. Sani, and your teachers. Dr. Aminu, please share your screen. Can you move to the next slide? And put it on slideshow. Okay, move to the next slide. All right, you have 10 minutes. Can go ahead.
Good morning, the facilitator. Good morning, our teachers, and good morning, everyone. I'm Dr. Aminu Bashir.
And I will be taking us through the question 9 of the 2023 May record. And the question is, as projected, a 48-year-old laboratory scientist with significant history of alcohol intake. He has weight loss as well and with history of jaundice. The questions are, what other histories would you take? What other examination findings would help you to arrive at diagnosis? You are asked to list differential diagnosis, 5 of them, and we are given some series of results, and we are requested to interpret the results. Then what is now the diagnosis? Haven't had this result at hand. What other investigation would you want to do for this patient? Then how would you treat the patient? Then what is the prognostic score called? Then what are the parameters? Okay, I just try to take the history realistically and see, and because this is just more or less like something that looks like history of liver-related problems, then we want to ask for history of non-specific symptoms. This is usually what they come with: nausea, malaise, low-grade fever. You want to ask for history of pale, bulky, foul-smelling stool and some pruritus. Possibly to ask history of deepening of urine. The jaundice that we were told started 2 weeks ago. We want to know the cause in the last 2 weeks, and if he has had previous history of such. If the patient has constipation, diarrhea, has had a history of upper GI bleeding and melena or hematemesis. We also want to see if the patient has started having some recent onset of insulin resistance, abdominal swelling, leg swelling, and you want to ask for history of fatigue in this patient as well. If you have started having features of hepatic encephalopathy, you want to ask for all of those. Also to check history of spontaneous bleeding from coagulopathy and all of those. You want to ask for those history. Importantly, you want to know the quantity of the alcohol this patient has been taking and which type, because since we know each of the alcohol, they have different constituents. So if it is beer, spirits, gin, locally brewed, or all of this, and what is the duration that this patient has been taking it? If the patient has made any attempt to cut down the alcohol used before, and what was the outcome? Was there any withdrawal symptoms? Smoking, you want to check history of other liver disease. And importantly, you also want to know if this patient is concomitantly using other drugs that could be hepatotoxic or herbal concussion. We are asked, what other examination findings would you want to do that will help you arrive at diagnosis? Generally and specifically, we want to check general examination, and all of these are more of examination findings that may look towards likely cirrhosis in the patient or some features of liver failure. So, or general examination, parotid fullness, altered hair pattern. You want to check for gynecomastia, spadial angiomata. You want to look at the hand of the patient for loss of tena and hypotena eminences and decreasing contractures, testicular atrophy, or if the patient has started having some flapping tremors and edema. Abdominally, of course, this patient may have some visible abdominal vein, hepatosplenomegaly, which may be tender, and ascites. We are asked to list some differential diagnoses, 5 of them. The top is alcoholic liver disease or alcoholic hepatitis. The next is metabolic dysfunction associated steatotic liver disease, which is the recent name for formal non-alcoholic fatty liver disease. Others are cancer of the head of pancreas, periampullary tumor, hepatocellular carcinoma, and metastasis to the liver. We are told to interpret the result that we were given, and we have elevated AST and ALT, we have WBC that is elevated, anemia, then MCV that is elevated. The liver enzyme elevated, AST more than ALT. Once you have the ratio, once you have above 1, it is expected that likely there is alcoholic liver disease. But once you have the ratio more than 2.1 in the presence of, if at this point you are giving GGT, and is elevated, then it's likely confirm diagnosis of alcoholic liver disease in the presence of the other symptoms and the history. The patient also, this is what is called the Ritis ratio, which has been long used for about 50 years. Leukocytosis is also what is seen here, and features of macrocytic anemia. These are the interpretation. Then based on this, the result that was given, most likely this patient has alcoholic hepatitis. What other investigation? With all of this, what to do other investigation that may be a pointer to either the diagnosis or complication that might have arisen from it. C-reactive protein has been found to be not too sensitive, but highly specific, with positive predictive value of 98% in patients with alcoholic liver hepatitis. This electrolytemia is usually commonly found in them, and you see mostly they have hypomagnesemia and hypophosphatemia, elevated creatinine and urea, because they vomit and all of this. Iron study, they have the ferritin and the transferrin saturation is usually high because of their photosystemic anastomosis, and they have higher absorption of iron. They have features of liver dysfunction, low albumin, the proton time, and all of they are all going to be deranged. Abdominopelvic ultrasound is usually what is advocated for, especially it is mostly available in our setting, and it's likely to pick whatever problem is there. But in advanced what CT and MRI are usually done. In very, very early phase, you may want to do fibroscan elastography, which will show features of very, very early fibrosis. In most instances, you don't need to do liver biopsy, but it may help to guide medical treatment, or when you are thinking of other alternative diagnosis, which usually shows ballooning with necrosis and focal polymorphonicular cell accumulation in the zone 3, and mallory bodies can be seen. Others want to screen for upper GI bleeding serologies, which may, if they have hepatitis, it may be part of what may worsen their outcome, and some serum biomarkers. How would you treat this patient? Generally and pharmacologically, you want it's more of the multidisciplinary approach. You want to gastroenterologist, and of course, this patient that needs to stop alcohol intake, you want to involve a psychiatrist. Then some other complications that may arise, nephrology, neuro, and infectious disease may be invited as well. Abstinence must be done, and usually it is recommended that we use a structured questionnaire for them to assess their use of alcohol and to assess for their tolerance, to know if the patient has had so much of tolerance, if they are worried that people talk much about them, and to eye opener and amnesia, and to know if they are already having the feeling to cut down, then you support them to stop. You want to give them medication to help them to stop, as well as manage the withdrawal symptoms that may happen. But it's of importance to give them nutritional support. Oral route is advocated, as parenteral or total parenteral does not have any significant outcome to that. Then you want to give them good calorie, and you don't do protein restriction except they already have encephalopathy. You supplement them on vitamins and minerals, then you give such restriction if they already have ascites. Vaccination is of essence because of the risk factor that may make them to worsen. This is what the alcohol use disorder identification test, that is audit concise, looks like. 3 questions, each of them 4. If patient has 4 for male, 3 for female, then it is likely they have alcohol abuse. Pharmacologically, you want to treat this patient if they already have coagulopathy, you give them parenteral vitamin K. Corticosteroid is of essence, especially if their discriminant function score is more than 32, or this patient has a hepatic encephalopathy. And this.
Yeah, 1 more minute.
Okay, and this shows that when you use this for them, then they have a better 30 days outcome. Prednisolone, according to the Stopper trial, it's superior to use of pentoxifylline. If in the absence, pentoxifylline may be used, which reduces viscosity, and as well it helps to reduce the portal hypertension and hepatorenal syndrome that may happen in them. The anti-tumor necrotic factor has also been used in them, which improves the discriminant function score and ultimately the patient's survival. Patients ultimately may require surgery if medical treatment does not, if they don't respond to medical treatment, especially when they are already in advanced stage. We manage complication as and the associated factor when they happen. Then the next question asks, what is the prognostic score that you want to use and what are the parameters? The prognostic score that is usually, according to the American Association of for Study of Liver Disease guideline, recommend that you use the major discriminant function score, which is used to stratify the illness severity and risk of poor outcome, usually in the initial phase and during the course of the illness. And the components, QT prolongation, total bilirubin level in milligram per DL, and with a constant of 4.2. Others, the middle score, the Chartpol score, the Glasgow alcohol hepatitis score, and asymmetric dimethyladenine score, which is the latest. Okay, I think I will not be able to go through the listing, but essentially it's just to know alcohol hepatitis mainly is a syndrome that is progressive, especially with heavy alcohol intake. The risk is diverse, and patients usually progress with heavy alcohol consumption, and it may eventually progress to cirrhosis if they continue, but there may be resolution if they abstain. The prevalence that is vary in different parts of the world, but importantly, it is in the Western world where they have data that they are able to see that it's quite high, especially about 1% of US population have alcohol-related issue. The pathophysiology is very, very important before I stop, since most of what we'll be discussing has been discussed in the question. Multiple factors have been implicated in the pathophysiology of alcohol-related alcohol hepatitis. Genetic factor, because of the fact that the gastric alcohol dehydrogenase is lower in female than male, so the female tend to have more susceptibility to having this because of their first pass effect is not there. The metabolic factor is what is most implicated during the metabolism of alcohol. The three major pathways, the cytosolic alcohol dehydrogenase, the microsoma ethanol oxidizing system, and the peroxisomal catalyst. All of this, when they metabolize alcohol, acetaldehyde is generated, which is very, very toxic to the hepatocyte membrane and the mitochondrial membrane. Then the cause problem, they alter the cell membrane, which forms some new antigen that usually cause some immunologic injury. And these pathways are usually highly catabolic, which is commonly seen in the zone 3, as we discussed earlier. They produce free radicals and they mop up all the glutathione that is needed to protect the liver. And since the NAD is used up, which causes accumulation of fatty acid, and which usually leads to steatosis. These are other immunologic factors that have been found, especially the cytokine, the tumor necrotic factor alpha, which is produced by the copper cell. They incite so much of cytokine that are hepatotoxic, and concomitant viral disease and acetaminophen use usually induce cytochrome P450 and deplete glutathione, and makes even normal dose of acetaminophen to be very, very toxic to this patient. This is
Can you round up, please?
Okay, so the clinical features, we have discussed that. Examination findings, we already discussed that. And the screening, we've already mentioned that use of the questionnaire. Diagnostic workup, we've said, talked about this, which is usually mild and it is straightforward to diagnose the management. Just as we talked earlier, I just did a little elaboration here. The prognosis, depending on if they continue or if they stop alcohol consumption, prognostic factor, and that is it. Thank you very much.
Thank you so much for that very lucid presentation. Back to your hands already. It was very detailed. Thank you so much. Okay, let me take a comment on the chat first. So Dr. Olaleko says, thank you for the excellent presentation. Will it be wrong to state the diagnosis as decompensated alcoholic liver disease rather than alcoholic hepatitis? All done. Okay. Then Dr. Justice says, thank you so much for the beautiful presentation. Just a few additions. Another consideration as a differential should be viral induced hepatitis. Okay, I think I shared the same thought. I was about to ask if it would be okay to use a chronic viral hepatitis as a second differential. So he continues, in view of the history of MSPs, and this should be evaluated as well. You could also consider a malignant transformation in view of the weight loss. Oh, thank you so much, Dr. Justice. Okay, okay, maybe just make a comment on that first before I go on.
Okay, thank you very much for that. Yeah, I have a couple, in fact, almost 10 differential diagnoses running on in my mind where I was preparing this slide, but I was just trying like, okay, since you're already given a particular treatment, it was never mentioned that the patient has hepatitis. So yes, it's part of what could have been added, but we are asked to give 5 differential diagnoses. As for decompensated alcoholic hepatitis, while I was doing this, it's just that okay, this will be decompensated liver disease, which may likely to be this and that. But while going through literature, all I only saw is mild, moderate, and severe alcoholic hepatitis with their symptoms. Mild being the fact that most of the time the patient may not present with any symptom, but moderate and severe are those that actually present in this particular way that the patient has been painted, this scenario has been painted. So that's why I actually don't bother to add decompensated to it, that this is more or less like what I particularly maybe could have added is maybe severe or moderate alcoholic liver disease. That was what I was thinking, but I'm sure our teachers are going to help us with that. Thank you very much.
All right, thank you so much. Okay, my question before Dr. Adeyemo comes up is for the prognostic scoring systems, you listed quite a lot. Thank you so much. But if we are asked to pick one, which one should we pick?
Why I was reading that's why I put the other ones as others. When I was reading, what I was able to see is that according to the American Association for Study for Liver Disease, alcohol liver disease, they said patients should be subjected to this moderate discriminant factor, which is going to be used to either help you to stratify the illness severity and as well risk of poor outcome.
Okay.
If you remember,
All right.
here, it stated that if it is more than 32, it indicates severe disease and indicate 30 days mortality rates. If they are only giving supportive care, telling you that you need to use steroid for this patient. However, the other ones are even more recent because that has been one of the old ones. The last one is the most recent, which was even stated to be better than the child post score, the discriminant factor, and even the MEDU score. But so that's when I have the bone of contention. When they said this is more superior, but they said virtually all patients should be subjected to the discriminant factor to guide use of steroid or not, which
All right.
for the outcome. So that's why I put that as the main answer. The management and co-workers discriminant function score.
Thank you so much. Okay, Dr. Adeyemo. Adedapo, please go ahead.
Yeah, good morning. Good morning. Thank you for the presentation. Good morning, our facilitators. Part of what I wanted to say has actually been taken care of, but just a little or a few additions. Yes, you talked about that the diagnosis is decompensated coronavirus, secondary to alcohol, meaning that alcohol is very important. Taking care of alcohol as the etiology is very important in these patients. So I was actually hoping that you talk about the role of the mental health physician in the management of this patient. It's very important that they could manage these patients with the gastroenterologist. The reason why this is very important is that there used to be this kind of argument whether a patient that has liver problem, liver cirrhosis, liver cirrhosis will benefit from liver transplant or not. Why? Because if they don't stop the alcohol intake, they will still go back to the alcohol, and even if you give them a liver transplant, the alcohol might still destroy a new liver. So very importantly, the etiology has to be taken care of, which is alcohol. So mental health physicians have to manage this patient with the gastroenterologist. Then also when you talk about the investigations parameter, I was also hoping that you talk about the ascites. It's very important to do a bedside paracentesis for this patient. The bedside paracentesis for this patient will actually help to know, one, whether the patient has actually ruptured a nodule or not, which is one of the markers of malignant transformation in this patient. So it is also used for prognosis, to prognosticate this patient. And apart from that, it will also help you to know if the patient has ascites, whether the ascites of portal hypertension in origin or it's not of portal hypertension in origin. And also one of the important differentials that you also have to look out for here is abdominal tuberculosis. Of course, we all know that cirrhosis is a risk factor for abdominal tuberculosis, and also analysis of the acidic fluid soup will also go along with also rule out the possibility of abdominal tuberculosis. In fact, it can also help us rule out malignancy as well, if we do cytology of the acidic fluid. Then you talk about the role of biopsy in this patient. Yes, fine. You might actually want to do a biopsy, but people are actually shying away from biopsy these days, because we have some non-invasive marker. There are some non-invasive markers that also have a high sensitivity as well as specificity in assessing the degree of stiffness or fibrosis in patients that have liver cirrhosis. You have quite a number of them. The APRI score is there, the FIFO is there, and some other non-invasive marker. Although you actually did mention about a transient elastograph, which is a fibroscan, but if that one is not available, you can actually make use of some of the laboratory parameters, your platelet, your AST to calculate some of those non-invasive markers of none of the non-invasive markers of liver fibrosis. Then also you talked about the findings on histology. Yes, fine. Apart from all the Mallory wave bodies, as well as the hepatocellular, as well as the inflammation of the hepatocyte that can result in necrosis of the hepatocyte. Also very important is the role of the cells that are also present when you take your biopsy. There will be an extensive neutrophilic infiltration, so it's also important to mention that as well. Then also when you talk about the aspect of the use of medications for benzodiazepine for the management of alcoholic liver disease, it's very important that if the patient has entered encephalopathy, you cannot use benzodiazepine. Usually, so for patients who have features of withdrawal symptoms, you might also want to make use of clonazepam. Is another medication also being used for the management of withdrawal symptoms when they come down with features of withdrawal. Then also, since alcohol is the main problem here, as part of the other questions to ask, I think it's also very important to also explore the effect of alcohol on other systems as well. For the alcohol to be as extensive to be causing liver damage, definitely some other organs to be involved, such as the heart, talk about the pancreas, talk about the nervous system as well, as part of other questions, that might also be asked, from this patient. Thank you so much for the beautiful presentation. Thank you for the opportunity given to contribute.
Well, thank you so much, Dr. Demo. Those very important additions. Dr. Kalamama, please go ahead. No, Dr. Florence.
Dictator, senior colleagues and colleagues. Okay, and thank you so much for your excellent presentation. Okay, mine is just an add-on. Okay, looking at the history of this patient is a laboratory scientist. And also in the history, okay, back to the history, please. Thank you. Okay, so this man is a laboratory scientist that deals with blood products. And then they gave us a history of multiple sexual partners. So I think that viral hepatitis should come very high up because of number one, his job, the nature of his job, and then there's a history of multiple sexual partners. Okay, then secondly, in the aspect of the decompensation, I think what can actually help you back it up, maybe the history of jaundice, and then also the AST ALT level greater than 2, which is showing that this patient has a cirrhotic liver. I don't know if that can also help you back it up to being a decompensated CLD with possible malignant transformation from the history of weight loss. Then going into the history, we can actually explore, yes, he has a history of multiple sexual partners. Is it unprotected? Is it protected? So in the history, we can actually add on: does he have unprotected multiple sexual partners? Then we can explore and also find out any history of does he protect himself from those blood products in the lab? Because sometimes we can be very careless. Then also history of sharing of unsterilized shafts under the history of sharing of unsterilized shafts, and then also scarification marks, and then any previous history of transfusion of unscreened blood. So these are things that can actually be added to the history in this patient. Then also under the signs, we can actually also look out for palmar erythema because we have different signs that we see in to differentiate between alcoholic liver disease and from hepatitis, that's hepatitis causing a liver disease. So the clinical signs can actually help us to differentiate. So palmar erythema can also be added there as one of the things, the physical examination, physical signs you can actually look out for in this patient. Then also, when you get to the investigations, other investigations that can be done, in alcoholic liver disease, they can have elevated gamma glutamyl transferase. So that can be added to the investigations, as well as 5' nucleosidase. So those can be added because it's associated with alcoholic liver disease. Then thirdly, we're thinking of a malignant transformation. I don't know, maybe I didn't listen, I didn't hear well. I didn't hear you mention alpha fetoprotein that can actually help us to rule out a malignant transformation in this patient. Then also, this patient has there's a history of jaundice and weight loss. We want to know if there's any history of CA to the head of pancreas. So I don't know, maybe I didn't see well. Maybe also another investigation is doing CA19-9 that can actually help us to rule out other differentials in these patients. Okay, so that's basically what I have to say. So far, so good. Thank you so much. Then for the biopsy, I think you can actually say micronodular and macronodular liver pathology, which can also help us differentiate between alcoholic liver disease and also liver disease from viral hepatitis. So these are add-ons I have to say. Thank you so much for an excellent presentation. Well done.
Oh, thank you so much, Dr. Florence, for those beautiful add-ons. Okay, so I think time is fast spent. Let me hand over to our teachers. Marcus.
Thank you. Thank you,
So-
Dr. Aminu. Thank you, Dr. Justice, Dr. Adeyemo, and Dr. Florence, as always. I always love our add-ons. Always very elaborate and important. So thank you so much. We appreciate all of you. We do. You reduce the job from our end. I don't know if Chief Cookie has any comment. Any comments? Chief Cookie? Okay. It seems she has left the call. So thank you, everyone. Chief Chitu, Bansi, Remigos, Fatima, Kopi, Dahatu, Dr. Sanda, any comments before we close the class? Okay. So Dr. Aminu and our wonderful contributors, thank you. You guys have done a